last one and the only one who is doing this session after or before his talk. So I'll explain a lot of things here probably in the next 30 minutes or so. But before that, I see a few parents here, I presume, remaining. So go ahead and shoot any questions that you have. Yeah.
Like our son's 15, I guess my question is like, because I worry about him as he gets older. Will he see different symptoms once he becomes an adult? I don't know what his life is going to be like.
Yeah, good question. So some of the most challenging and tricky times in our clinic is if we have more than one or two relapses, because the majority of kids, they don't have any relapses after their first attack, and then about the third or so that do, they have maybe one or two attacks, and then we see the rare ones that have more frequent attacks. And yeah.
That's what I was hoping for, that it would be like a one and done.
Correct.
You know, so, and we haven't been that lucky. So when he's doing great, but then, yeah, he's, you know, and I'm an old dad, so I worry, like, what's he going to be like when, you know.
Yeah, I can only imagine those worries. Of course, in pediatrics, we see that worry more than if you're the child itself, right, most of the time, because the answer most of the time from teenagers is that I don't care, I don't know. And after that, you have to prod a little bit more. But if you have numerous relapses with good recovery after that, and the question is always, indeed, as you said, are they the same symptoms? Are they pseudo-attacks? Are these symptoms that have clear lesions on an MRI, new lesions, and then we really strongly feel that? Or could at times be there something else? Could it be anything that we need to look into with a little bit more detail? And it can be quite challenging to distinguish some of these as we see some unusual and atypical symptoms in teenagers also that do not have any underlying MOGAD or other similar disease. And so sometimes teasing those apart, what is clearly MOG and what is not MOG, that's probably the hardest part of our job. And at Mayo Clinic, we have at least the fortunate part is that we have the time to kind of investigate, because people come from far away, and we have that time and luxury of having that thorough way to look at that, where in many other places you have maybe a 10 or 20 minute appointment, and it's like, oh gosh, we see this in multiple sclerosis too. Oh, it's a new symptom, fits with MS, must be MS, here's your steroids, and then it gets better. And so that sometimes can be quite challenging. So not knowing the further details of that is that we do not know the long-term trajectory in great detail. But the times that I've seen kids come back later, and of course, many of the kids follow up locally after they come to see us, but the ones we have seen is really less than a handful of kids that had another attack, like say 10 years later or so. But 10 years at this point, right? So 10 years ago from that point was, well, we had some sample research saved and we looked at it. So what happens down the line in an adulthood, nobody really knows. And we're hopeful that it stays that way, that it's most of the time, again, it's either a single or a few, and then things kind of stop. And the other part that we commonly see, if there are ongoing relapses, the majority of the time they become less and less severe, which is kind of curious and interesting too. And so, again, that's a very long-winded answer to, I don't know. No, there are good pieces there that we do know, and then there are some of these unknowns still, and that's why we're keeping on following patients with this. We have a very large network of pediatric MS and demyelinating disease centers across the United States.
This place is great.
Yeah, and so so we will know more about it, but at this point, that question to what's going to happen down the line and in the future, most of the time, and the majority of the time, it's good, but
Because this has been a great experience coming here this weekend. Because we live in Indianapolis, and
mhm,
so when he first got diagnosed, like nobody's ever heard of it, and there was a lot of tears in our house, you know.
correct.
And he has I like his neurologist now, but he only has one or two children, so
Mhm.
I just feel like we don't always get the latest information, or, it's just like, hey, because right now he does IVIG
Mhm.
and rituximab, which really doesn't do anything for him. But we're lucky enough, we're going to be back here in a couple of weeks
Mhm.
to meet with Dr. Flanagan and possibly see about the trial.
With the team in the trial. Yeah, no, that
So,
sounds-
yeah, we're pretty excited, looking forward to that.
Yeah, and I'll let them know if there's anything, because most of the time here, if kids are under 16, but the majority of the time under 18, they come to see me. So I've pretty much seen everybody here in the last 12 years that came through here. And so we get that often, right? And it's going, well, gosh, this was mentioned, and our local doctors, they had no clue what to do. These days, with more publications and things that are available online from some of the work that we and others have done, it's becoming more clear and more apparent. And so that question of nobody knows what to do has gone a little bit, in my experience, a little bit less and less. And probably in the next few years, I'll be seeing less patients because the majority of them will be treated locally with some good information. And again, many kids do really well with it. It's
Because it was the Mayo Clinic that picked it up.
mhm.
That's how we found out. We got a couple different things before that, so
Yeah,
that's how we found out. We're like, well, what is it?
yeah, yeah, absolutely.
There is a question, I think, from online. Oh, sorry, and then
So the question is, my son is 9 and had his first attack when he was 8. If there is going to be a second attack, what is the average time between the first attack and a relapse?
Good question. So what we do know, and I'll explain that further in the talk here in a little bit too, is that the majority of the attacks happen again in the first 12 months, and the majority of them, the vast majority of those other ones within the first 3 years. And so that's where the rationale of not doing long-term IVIG, unless if you have a relapsing and ongoing relapsing course after you stop the IVIG, comes from. So many times we basically have the plan of let's cover things for a year or 2 years. Highest risk is done, then we go hopefully after that to the part where we don't have any of the relapses. But as I mentioned, the one or the few outliers have been many years after the initial attack, and so typically we tell parents, and then mostly teenagers too, is like, hey gosh, don't ignore this when this is happening, right? When you're 20 and in college or working or anything, and you have a little bit of a mild blurring of your vision, you say, gosh, I'm not going to see the doctor, right? That's not an uncommon thing for young adults to do. So we really kind of hammered that on that part too. So never fully out of the woods, but the most of the repeats come in the first year.
I have a million questions for you, but I'll just kind of try to stick with one here. Our journey, I thought it was a long one, but ours started last November, and it seems like, and it's just been messy, and it sounds like everybody's kind of dealt with it longer, so I'll just try to be as patient as I can. But our daughter continues to have seizures, and they're extensive and ongoing. It seems like every other month, and we just can't seem to get a handle on it. But my question for you is, recently now her GAD 65, in May it was 0, in July it was high, so now we're doing further testing there. My question is, do you find these autoimmune things, like do they come in groups? Do they, like if a child is diagnosed with one, is it likely like we're going to find more as time goes on? Can we proactively dig ahead of time? Like, how do we find this out before we get kind of
Yeah.
blindsided? Thank
So
you.
the first question there typically is there IVIG on board?
She's doing them once a month right now,
The-
since
the
April,
likely- the
since we
likely-
relapsed.
The likelihood of that GAD65 coming from herself is very low. The more likely part is that the majority of GAD65 that we see is a very low titer. And the reason why they keep that low titer as the cutoff is because of other disease like diabetes, and they've just set it up, and that's just the way how historically it has been. The majority of them are, 0.05, 0.1, in that kind of range. We don't see neurological symptoms based on some of the studies that we've done until they're greater than 20. And so the low amount of GAD65 typically comes from the IVIG, because a small percentage of people walk around with those antibodies and never know anything about it. And so that's the most common time when we see, because these immunoglobulins are drawn from numerous blood donations. You get the immunoglobulins that are basically kind of pulled out from that. So you get them from multiple sources, and so the GAD65 after that, unless if it's sky high, we typically ignore. Over 20, then we start kind of getting curious. And the thing is, for GAD65 in general, is that if you don't have it in your spinal fluid, it's unlikely that it's causing any major symptoms. In the setting of seizures, as you mentioned, it is something that one would take into consideration. But many times we see that low positive, we see low positive rheumatological markers. And most of the time, so if I have somebody with one of the rheumatological markers elevated and I send them to rheumatology, they say it's probably a false positive. Or some people, same thing, carry those antibodies around. And so if anything, the only thing that we typically see, it's kind of some marker of some autoimmunity kind of risk, right? If you have one of them, the risk that you have another one is higher. And so careful assessment of that is done, typically, yeah. Good questions.
Okay, we have 5 minutes, so
And
if
we can
there
head
is-
to the, we have go over a lot of things here in a few
Okay.
minutes too, and I'd be happy to answer any of your questions after that.
Wonderful. Thank you all.